All right, welcome to the Explainer. Today we're going to take a deep dive into the male reproductive system, but with a twist. This is a visual journey designed to get you exam ready. We're going to map out the step-by-step process, the pathophysiology, of a few key disorders. The goal here? To really help you see what's happening inside the body, so you get the why behind the symptoms you'll be tested on.
So here's our game plan. We've got 4 big stops on our anatomical journey. We're starting with urethral strictures, then we'll look at Peyronie's disease. After that, we'll tackle the emergency that is testicular torsion, and we'll wrap things up by looking at the HPV pathway in penile cancer. Ready? Let's get started.
Okay, first up, the urethra. We're calling this section a narrowing path, and that's exactly what we're talking about. We're going to break down the mechanics of urethral strictures, which is when this critical passageway gets, well, dangerously narrow. So, let's get our bearings with this image. What you're looking at is a cross-section of the penis. See that channel down at the bottom, inside the spongy tissue? That's the urethra. Now, a stricture is basically a scar, a narrowing that happens inside that channel. It's like a kink in a hose, creating a bottleneck that makes it really tough for urine to get out. It's all about that obstruction.
So how does this bottleneck actually happen? Well, it's a pretty clear chain reaction. First, you've got a trigger. Think an injury, maybe from a catheter or some kind of trauma. This damage lets urine leak out of the urethra and into that surrounding spongy tissue. Now, the body's response? It freaks out. It sees urine where it shouldn't be and kicks off a big inflammatory response. This leads to scar tissue or fibrosis. And here's the kicker. That scar tissue isn't flexible like normal tissue. It actually contracts, it tightens, and it literally squeezes the urethra shut. And that's when you get the symptoms, right? A weak stream, feeling like you can't empty your bladder. It all comes from that simple cascade.
All right, let's shift gears to our next topic, Peyronie's disease. We're calling this an injury that lingers. And it's actually a similar story of wound healing gone wrong. We're going to connect the dots between trauma and the formation of a fibrous plaque, a plaque that leads to a pretty noticeable physical change.
Okay, this slide is perfect because it shows us both the outside and the inside of the story. On the left, you see the clinical result, that signature curvature of Peyronie's disease. On the right, we see why it's happening. The problem is a hard fibrous plaque that forms in a specific layer called the tunica albuginea, which is the sheath around the erectile tissues. That plaque is like a patch of concrete on a balloon. It just doesn't stretch, and that's what causes the bend. So let's focus on that key structure, the tunica albuginea. Just think of it as this tough, super elastic sleeve that wraps around the erectile chambers, the corpora cavernosa. It's supposed to stretch nice and evenly. But with Peyronie's, a patch of that stretchy fabric gets replaced with stiff, inelastic scar tissue. That's the plaque. So during an erection, the healthy part stretches, but the plaque, it can't. It just stays put. That creates a pivot point, and boom, you get that bend. So what puts someone at risk for this? Well, no surprise, penile injury is a big one. Even microtraumas can be a trigger. But look at the other factors here. We've got connective tissue disorders like Dupuytren's, family history, low testosterone, and diabetes. What's the common thread? A lot of these things mess with the body's ability to heal properly. So when an injury does happen, the healing process goes haywire, and you're much more likely to end up with that hard, fibrous plaque instead of normal tissue.
Okay, we need to completely change gears now. We're moving from these slower, chronic issues to a flat-out, sirens-blaring urologic emergency. This is testicular torsion, and it's all about a race against time. This isn't a slow burn problem. This is a sudden, acute event where the blood supply gets completely choked off. And when I say it's a race against the clock, I mean it. And this image right here shows you exactly why this is so urgent. This is what happens when you lose that race against time. The testicle has literally twisted around its own lifeline, the spermatic cord. The best analogy is twisting a garden hose until the water stops flowing, except here it's blood. And without blood, there's no oxygen. The tissue becomes ischemic, and if it goes on for too long, it becomes necrotic. It dies. That dark, discolored tissue you see, that's what's at stake. Okay, if there's one thing you need to burn into your brain for your exams, it's this timeline. The clock starts the second the pain begins. If you get to surgery in under 6 hours, the chance of saving the testicle is really high. But look what happens next. Between 6 and 12 hours, viability drops off a cliff. And if you go past 12 hours, the damage is usually irreversible. We're talking necrosis and loss of the testicle. This isn't just important, it's absolutely critical. Every single minute matters. So because this is such an emergency, you have to be able to tell it apart from other things that cause similar pain. This table is your best friend for that. It's your clinical cheat sheet. Just look at the key differences. Testicular torsion, super sudden acute pain, usually in a teenager. Now compare that to, say, epididymitis, which is more of a slow buildup, or appendiceal torsion, which tends to happen in younger kids, and the pain is more localized. Getting these details right on the history and physical exam is what tells you, okay, this could be torsion, we need to go to surgery now.
All right, for our last stop, we are zooming way in, all the way down to the molecular level. We're going to talk about penile cancer, specifically the pathway caused by HPV. And this is fascinating stuff. It's literally about how a virus can hijack a cell's own programming and turn it against the body. Now, I know this diagram looks a little intimidating, but just think of it as a battle plan. It shows how two tiny viral proteins, E6 and E7, carry out a perfectly coordinated attack. These are the bad guys, the main oncogenes from high-risk HPV. Their mission? To find and destroy the cell's own safety mechanisms, the very proteins that regulate growth and, importantly, tell the cell to die when it's damaged. So let's break down that attack with a simple analogy. Think of your cell's life cycle like a car. The E6 protein comes in, and its job is to cut the brake lines. It goes after a protein called P53, which is the cell's master tumor suppressor. It's the emergency brake. E6 takes it out, so the cell can no longer stop itself or undergo programmed cell death. Then, while the brakes are out, the E7 protein comes in and slams the gas pedal to the floor. It takes out another key protein, PRB, which is what normally keeps cell division in check. So what do you have? A car with no brakes and the accelerator floored. That's a recipe for the disaster, or in this case, uncontrolled cancer growth. And this quote really sums up the final result of that attack. The key words here are persistent or recurrent exposure. It's not usually a one-and-done infection. It's the virus sticking around that allows it to actually weave its own DNA into the cell's genetic code. And once that happens, it's game over for that cell. It is now permanently hijacked, and it's on a one-way trip to becoming malignant. So there you have it. We've gone from a simple plumbing problem in the urethra to a wound healing issue to a time-sensitive emergency and all the way down to a molecular hijacking by a virus. I want to leave you with this question to think about. How does really seeing the step-by-step cascade of a disease, visualizing it from that first trigger all the way to the final symptoms, how does that change how you're going to think about diagnosis and treatment? Not just for your exams, but for your entire career. It's something to chew on. Thanks for joining me for this explainer.